Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Team Ready, Turning Claims Data into Financial Performance. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Angie Caldwell, Leanne Odom, and Jason Harden.
We have a robust agenda for you today. First, we're going to level set, understanding that not everyone in the audience may be familiar with TEAM. We briefly level set. Then we are going to have a discussion about shifting to track 3 in 2027, talk about data as the foundation to everything that we do, and then talk about barriers to insights into that data for you, and then thinking about monitoring that data and taking insight to action. So let's jump into our TEAM overview. So as you may know, CMS TEAM is a mandatory 5-year bundled payment model. Mandatory to whom? There are about 743 hospitals, over 187 CBSAs that are required to participate in CMS TEAM. So hospitals are accountable for total episode cost and quality. So from beginning to end, the episode spans an anchor hospitalization or procedure through a 30-day post-discharge period. So the entire period the mandatory hospital is responsible for. Success requires management really across the full continuum of care, across all providers within that continuum of care. Performance, of course, then can be affected by cost and care variation, avoidable complications, and really post-anchor utilization and care variations. So TEAM is intended to help you reduce variation, improve outcomes, and protect margins within your hospitals. So thinking about which surgical episodes are within TEAM, there are 5 different surgical episodes, 2 lower extremity joint and spinal fusion that can begin, that anchor period can begin either as an inpatient or an outpatient. The remaining 3 are inpatient only: major bowel, surgical hip and femur, and CABG, the coronary artery bypass graft. So all of these, again, are tied to TEAM, and with, again, the clarification that 2 of the 5 can begin in either the inpatient or outpatient setting. Jason?
Sense of urgency shifting into 2027 as the risk structure changes. Many hospitals will be required to shift into track 3. Many organizations chose as an option to be in track 1, which has upside exposure only. 2026 is used as a runway for many organizations before transitioning to exposure in track 3. So I'll briefly go over the various tracks and what this means for organizations, beginning in performance period 1 and then performance period 2 through 5. So in track 1, it's upside only, up to 10% of the target price. So we have a target price for each individual episode multiplied times the volume for each applicable episode. Track 2 is an option for fewer hospitals. Most of these hospitals, you see the footnote we have on the slide, this would be rural hospitals, Medicare dependent, sole community hospitals, etc. In large part, many of the hospitals transitioning into 2027 or performance period 2 have upside and downside risk of up to 20%. So really, year 1 needs to be used as a runway to be able to prepare for the financial risk exposure going into the following year, 2027. Let's go through an example to see what downside risk is for an example organization we've called ABC Hospital. So in 2026, ABC Hospital elected to be in performance year 1 upside only, or track 1. If they performed unfavorably during this period, they're not penalized since, in fact, it's upside only. In 2027, being required to go to track 3, they have downside exposure and upside. But if you look at this example, their downside exposure, if we quantify in the right rectangle, if they had a total target price of $20 million, their maximum repayment exposure would be $4 million, or 20% of the $20 million. So really, the time is now. Using the baseline data prior to performance year 1 and using early data from performance period 1 to be able to reduce your downside exposure moving forward. So now I'm going to touch on data being the foundation. Many of you have likely evaluated the baseline data. For some of you, you may not have. And I think it's really important to make sense of that data, because using that data allows you to be ready as you move forward into the at-risk performance years. So quantifying risk, identifying variation, engaging stakeholders, and to begin targeted interventions. What can you do with the data? What we see with a lot of organizations is some may not know what their exposure is. It's upside only in year 1. Has your organization quantified the downside risk exposure in 2027 performance period 2 and beyond? You can only manage what you can measure. The claims data provides the base for team performance management. So understanding your downside exposure is the first start, like the example that I showed on the previous slide. The baseline claims data provides the starting point for estimating exposure relative to target prices, with the goal being to understand where performance is relative to the target and where volume concentrates risk. So you may have, of the 5 episode categories, you may have 80% of your volume in 2 episodes, for example. It may be in lower extremity joint replacements and spinal fusion. Those may be the 2 areas to initially target due to the volume and the risk that those episodes would present. This is an executive view of the risk. It doesn't show the actual root cause analysis. But once exposure is quantified, the next step is understanding why. So let's advance to the next slide and diagnose the drivers that you can evaluate with the data. So leaders need to pinpoint the underlying sources of variation. So understanding variation in length of stay, readmissions, discharge disposition, unwarranted utilization, and then evaluating care setting drivers in skilled nursing, inpatient rehab, and other post-acute care settings. Looking at variation by physician, looking at practice patterns, episode costs, and outcomes. The baseline data and early performance year 1 data helps to identify opportunities early before downside exposure takes effect. As I mentioned previously, being able to focus your efforts on the high-risk areas where you have significant volume based on the episode volume you have in this program. I think the mistake some organizations can make is trying to address everything at once. And this is where I think prioritization is essential. Focus on the episodes and settings with the greatest opportunity. As I mentioned, high volume, high variability, and make sure there are clear operational levers that can impact opportunities to perform successfully in teams. Examples of high impact priorities are avoidable readmissions, unwarranted post-acute utilization, and physician level length of stay variation. Many organizations have the data we found, but they struggle to make it actionable. Let's go through some of the barriers to actionable insight. So having the claims data does not automatically produce decisions or operational change. These are some of the common barriers that we see that organizations face. Data fragmentation. When you receive the data from CMS, it's often siloed. It sits in a variety of files. You have inpatient, outpatient, post-acute care files for the separate post-acute care settings. And what this really does is it limits you able to see the entire care journey and the full view of the episode. Another constraint we see is just having the analytical staffing and know-how. Having limited tools and limited staff, it really slows the move from raw data to decision-ready intelligence. Similar to this, it's the complexity of the data. Not being familiar with the data and knowing how to present the data, important signals can be lost without clear visualization and actionable analytics. And the end goal is really this: your leadership needs to be engaged. If they're not engaged, they're not able to impact change or really know what to change. So it needs to be relevant, understandable to executives, physicians, and operational leaders to drive action to be successful in team. I'm going to share a dashboard to address some of these common barriers by integrating the episode view and providing decision-ready insights. The next few slides show examples of dashboard views and the specific decisions each view supports. Raw claims data alone doesn't drive improvement. Leaders need decision-ready intelligence. The dashboard that I'm going to provide an example of and walk through, it integrates episode views across the care continuum, shows timely reporting of core metrics, utilization patterns, and financial indicators, provides leaders targeted insights into care setting drivers, physician variation, post-acute outcomes, and outlier episodes. What's key is not just having a dashboard, but having one that has stakeholder engagement. You need executive-ready visuals that clinical and operational teams can interpret to be decision-ready. Leanne, any thoughts you have from your operational experience, using dashboards and really making them actionable that you would like to share?
Yeah, Jason, I appreciate that because, of course, as you're talking through the data and the way that you and I partner from a data and operations perspective is exactly the same way that in health systems and organizations, how they work together, right? So you have talked about, we're going to look at dashboards, we're going to look at data, and multiple key stakeholders will be using these and need to be lockstep engaged with each other. And everybody brings a particular perspective, expertise, lens by which they see things to the table. And it really is, to affect change, it really is a true partnership between the individuals that know the data, the individuals who bring the financial perspective, the individuals that bring the clinical perspective, the operational perspective, to bring all of that information and expertise together to figure out the right path forward to make positive changes. So I think as we go through these dashboards, it is important to really think about what multidisciplinary team and partners do we need at the table when we're going through this journey to figure out what is best for the patients in the organization.
Thanks, Leanne. So now we'll take a look at an overview of several dashboards and each view, what it means and how it can help you navigate through TEAM. It's going to allow you to understand where performance is off target, what's driving the performance that's off target, and where's the first place to intervene. So we'll start with an executive overview dashboard, another view that will evaluate anchor versus post-anchor costs, physician performance. Then we'll do a deep dive on post-anchor care. We'll evaluate cost by care setting, and then we'll look at the last view, which is called the episode journey view, that allows us to look at the entire continuum of the journey through a patient's episode. So starting with the executive overview, this is a starting point that shows you the overall performance by episode category and setting. So what we see here in the dashboard, we see the overall volume in the top left. We see 665 episodes. We see the average cost of approximately $44,000. And then we see the cost compared to the target, or what's referred to as the net payment reconciliation amount. This would be the overall cost for all episodes in this context, all 5 inpatient and outpatient categories of episodes, minus the target price. This would be the preliminary target price for baseline data that you would have at this point until you receive performance year 1 data. Let's go to the next slide to zoom in on this overview. And what we see of the 665 episodes, we see that nearly half of the episodes are in excess of the target. As we go to the first table, we can see the 5 episodes, inpatient and outpatient, 2 of which, as Angie mentioned, are applicable to inpatient and outpatient, lower extremity joint replacement, and spinal fusion. What we see here is the variance from the target. So the variance from the target, we see a number of unfavorable variances. We see a favorable variance for surgical hip and femur fractures of $211,000. When we identify the variance for lower extremity joint replacements, this is where we see 400 of the 665 episodes. That makes up 60% of the overall episode volume in this period. Outpatient is actually favorable for those episodes, but inpatient, we see the largest unfavorable variance of $345,000, and that's where slightly less than half of our overall lower extremity joint volume is. So let's use the dashboard to identify the root cause of the unfavorable variance of $345,000. So as we look at lower extremity joints, we see of the 194 episodes, more than half of the episodes are over target. We see that 55% of the overall cost is post-anchor. So this is after discharge from the acute care stay. And we see that the post-anchor episode cost for the 194 episodes is just over $4 million. Let's go to the next slide to dive in further to lower extremity joints. So now we're looking at the anchor versus post-anchor analysis. So what we're able to see are the readmission rates for all 455 episodes. We see that overall it's 7.3%. We see for spinal fusion, it has the highest readmission rate at 12.7% of the 55 episodes. What's interesting, when we look at inpatient rehab, we see that approximately a third of the spinal fusion episodes receive inpatient rehab. If we look at the bottom left stacked bar chart, what we're able to see is the overall cost by episode type and setting. So the gray bars we see are the anchor cost. Everything to the right of the gray bars is the post-anchor cost. So for example, for lower extremity joints, that's the second from the last bar, we see that 15% of the overall episode cost is from inpatient rehab. To look further at inpatient rehab, we'll dive into this in a future slide. What I would like to do is transition. We're going to filter this dashboard for lower extremity joints. We see the same variation, the $345,000. And then the next slide, we're going to look at variation by operating physician. So when you look at variation by operating physician, we're able to see each of the 194 episodes, and we're able to see the outcomes and variation by provider. The context in which I have this dashboard filtered, I'm showing the variance, so the total cost less the target price, and I see a number of providers that are contributing an unfavorable variance that flows through to the net payment reconciliation. So doing a deeper dive on these episodes for these various physicians may allow you to uncover some variation in the care provided for these patients that receive lower extremity joint replacement episodes in an inpatient setting.
And Jason, I'll just weigh in here, particularly as it relates to the physicians that have higher variation or higher differences from the target. Those would be the physicians from a collaborator agreement or other agreement perspective that you would want to have a discussion with and try to seek that alignment and engagement, especially with those that are revealed in this particular view within the data.
Thanks, Angie. Next, still filtered for lower extremity joints inpatient, what we're looking at now is the post-anchor deep dive view. What this allows us to do is look at the post-anchor providers and post-acute care providers, including readmissions back to a post-acute care facility. We see that for inpatient rehab, we see that 45 of 46 of these 45 of 46 of these episodes that did receive inpatient rehab care had total cost in excess of the target price, almost 98%. So this allows you to not only understand how the cost of providing inpatient rehab impacts each episode, but it also allows you to see the specific facilities. Is it a facility that is part of your organization, or is it perhaps an external facility that could benefit from refining discharge planning, strengthening transitions, or optimizing post-acute utilization with more targeted interventions? If we looked at skilled nursing, home health, hospice, we could see the impact that each of these post-acute care settings, along with readmissions, impacts each of these episodes. Next is the episode cost by care setting. I really like this dashboard. I think it's aesthetically pleasing, and it allows you to understand in a visual manner for executives to know which episodes are in excess of the target price. So the blue horizontal line you see here is target price. This is for lower extremity joints, and I've specifically filtered for DRG 469. What we're able to see is each individual episode that is in excess of the target price, with the least favorable episode on the left, and it becomes more favorable or closer to the target price as you advance to the right. And you're able to see by each care setting the components of cost within that episode. So for example, we can see here in the purple, the second episode and the first episode, that this is inpatient rehab. And then you can actually hover over and see a tooltip to be able to identify the length of stay at that post-acute care setting, any readmissions, where the patient was readmitted to. Were they readmitted to your facility or readmitted to another facility for that readmission event? The
Jason,
next slide.
I was going to say, before we move off of this slide, Jason, what I really like about this slide from an operational perspective is it gives you a sense of the anchor stay or event length of stay as well, and coupling that with the readmission. I think oftentimes our mind automatically goes to kind of downstream in what is happening in those 30 days or in the post-acute care setting. But there is a lot of opportunity, particularly in these episodes that go beyond the target price in that initial anchor stay, as well as the readmission space.
Thanks, Leanne. And what's not shown here in the visual, but as you select each episode, you're able to see a tabular view of the cost and specific anchor stay, and then any post-anchor activity. This next dashboard is the episode journey dashboard. So this gives you an opportunity to see longitudinally how the episode unfolded. Not just the cost, you're also able to see the cost compared to target, but it allows you to see from post-discharge to 30 days post-discharge what unfolded. So let's look at this example for inpatient spinal fusion. We see that the total cost is $58,000 with a target price of approximately $30,000. This results in an unfavorable variance of almost $28,000. Here we can see a tabular view of what unfolded, the length of stay, the start and end dates within each setting, and cost. But what I really enjoy seeing here is you can understand the patient journey by looking at this through a visual perspective. So we see that this patient is admitted for inpatient spinal fusion. They are then discharged to an inpatient rehab facility. The cost is $33,000. And we can see days after this patient is readmitted. So in addition to the professional services, DME, the anchor stay, it's the inpatient rehab and readmission that contributed to this episode having an unfavorable variance of $28,000.
So, Leanne, would you mind to share with us, looking at this particular view, how then you would take this information and then begin to dig deeper and perhaps focus within an organization related to this particular view? I too really like the timeline and how this really pinpoints where the costs are adding up over the course of an episode.
Angie, that's a great question. And all great questions lead to more questions, right? So as these, particularly as we look at the episode journey, the top question is always why. And you ask why until you can't ask why anymore. So when you have the information set out like it is, segmented, and you can really see particularly the path, if you will, the length of stay, the cost, it does invoke all of those why questions. Why was this particular segment the length that it was? Why did the care transition result in an inpatient rehab stay? Why was the patient readmitted? And well, particularly as you're looking at a whole load of episodes and you're digging deep to ask to find those variations, and you keep asking yourself why, inevitably you'll have to do a lot of individual chart reviews, right? You're going to have to go into each chart and really figure out what the whys are. But what will happen is that you will start to see patterns emerging. So later on, we'll talk about how do you take all of this information and what are the operational considerations? And the biggest operational consideration is to say, what patterns are emerging, and then what can I do about them?
Fantastic.
So it's about asking why. It's sleuthing.
Now I will turn it over to Leanne. She's going to discuss ongoing monitoring and execution to succeed in TEAM.
Thank you, Jason. You have spent a good amount of time getting us laser focused on the data. And what we would like to do now is to say, how do we take all of the data information that you've had a chance to preview and say, what do we do with it? And how do we look at it in a way that triggers that why questioning? And oftentimes the why questioning leads us upstream, if you will. We all know from an operational perspective that there are leading indicators to get us to where we're at. So we know in any dashboard or operational metrics that we look at that there are a variety of things that lead up to the outputs that we are seeing. And team performance is no different. So team performance requires ongoing monitoring. It requires continuous readiness, if you will. And it also requires the ability to be able to assess your current state and say, what sort of operational measures do I need to have in place that will support those outputs of the quality and financial improvement that we're all talking about? So as we consider the thought of tracking lead indicators, I would be remiss if I did not mention structure first. So we've already talked about key stakeholders and how that's a multidisciplinary team. And the multidisciplinary team is comprised of individuals with varying points of view and various expertise contributing to that thought process around what does that operational measure dashboard look like. So it's really important in your structure as you're forming, or perhaps you have already formed, governance structures or steering committees or whatever you might call them, a multidisciplinary venue that has financial perspective, quality measurement perspective, operational perspective, physician leadership perspective, executive leadership perspective, all of those very important inputs. Because particularly as we think about those lead indicators and we want to go upstream, we want to think about those operational things that contribute to that patient journey. Some of those things are things that are listed here in no particular order, but do I have a clinical practice guideline that I use? Are people actually using the clinical practice guideline if I have one? Am I currently measuring readmissions? If I am, what do I do with that information? Do the physicians know? Have I gotten patient feedback on what brought you back to the hospital? Length of stay variation. We all know that we measure it, but have we shared that information with our physicians? Also, thinking about discharge disposition patterns, who's using post-acute services and why. Again, are we sharing that information? So all those things that we are probably measuring today, but do we have the right structure and venue in place to really have that discussion and say, what else do we need to be measuring? So what do those operational measures look like? So we have a few things here for you to consider for operational measures. Many of the surgical episodes in TEAM are elective. Now, not all of them are elective, but many of them are. So particularly when you're dealing with an elective situation, and Jason took us through lower joint replacement, which is a great example of an elective procedure. It really begs the question around what are you doing with pre-operative optimization activities? So we already talked about the care pathway. Are you measuring it? What are you doing in the space of patient and family education and engagement? Are we measuring that? How are we improving the timeliness of care transition? What is the role of the family and using the different care level transitions there? Is somebody going home with home care with family support because you've spent a lot of time in the optimization phase really working with that family and educating them? And that really gets to how do you reduce all of that unwarranted post-acute care utilization for that particular care setting. So there's a lot of operational measures, particularly with a population that is elective, that can be focused on to produce results. We're going to go ahead and think about how do we start really taking these insights and executing them in a way that is very visible. And you've seen some screenshots around the dashboards. We've talked about lead indicators and how are you putting that information out there. What we're really looking for with these dashboards is to say, how are you highlighting those high cost areas, how are you finding those physician level variations that are unnecessary, and what are you doing with them? So, as we think about the visibility and the execution and how you really focus on high impact interventions, that is unique to each organization and where you all are at in your journey, because how you take care of patients is a journey. And I already mentioned structure, and the structure that you have supporting in each of these areas is something that evolves over time. That multidisciplinary team evolves over time, and it does develop into a place where standardized care pathways are just part of what you do. Standardized care pathways can help decrease variation amongst physician practice patterns, how the team practices together. It can help with timeliness on a variety of transitions, whether it is a preoperative transition into that anchor stay or episode, or it's a transition from that stay into the post-acute services. And it also can address how you collaborate with those post-acute care plans in that post-acute care space as well. So we have spent, as we wrap up, we have spent a great deal of time talking about the data, looking at various views. We have spent just a little bit of time, just the tip of the iceberg, around how do you take that information and use it to make operational change or impact. That is all highly dependent on where you're at in your journey, highly dependent on assessing current state and developing that multidisciplinary team to affect change. So, as we wrap up today, we look forward to supporting your journey, whether it be part of data or helping with any of those operational considerations. Please reach out. Thank you very much.
Thanks to our presenters, Angie, Leanne, and Jason. The slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.